Okay. Thank you very much for the invitation. Good morning. So I'm going to show a case from our hospital, from the Onassis Hospital. It's about a young female, 32 years old. She has a dilative cardiomyopathy with an LVEF for 30%. As you see, she has all the optimal heart failure medication. And although she has all of this, she has dyspnea in mild exercise and recurrent cardiac decompensations. We screened her in the coronary angiography. She has no stenosis. Of course, she's 32 years old. We did perform a right heart catheterization, where she has a pulmonary hypertension from 47 millimeter Hg. In the echo, we saw a severe MR. As you are seeing in the images, we have here in the mitral valve a tenting from both leaflets with recurrent severe MR with a pizza zone. And as you can see in this slide, the MR is going through the whole valve. Afterwards, we performed a transesophageal echocardiogram in order to see how the leaflets are, what the anatomy is, and if she's suitable for perhaps a TEER. As we are seeing here, we have both leaflets are large enough in order to perform TEER at an M-TEER, and as you see, she has two jets, if we can see that, and it's one in one medial and one in the lateral side. A few words about the MR classification. We have the first classification, it's the quantitative with mild, moderate, and severe, and we have the Carpenter's classification, that's a morphology classification. In this case, we are talking about a Carpenter 3B, that's the tenting from the leaflets with a restricted closure during systole. It's a functional MR, we can say. Here from the guidelines about how we quantitative can make the classification from the MR. As you can see, I would tell only a few of that. We need a vena contractor width from above 8 millimeters if we are talking about a biplane, a ROA from above 0.4 millimeters, and we have a dilated left ventricle, a dilated left atrium, and a holosystolic jet. Also from the guidelines, we have a workflow. We at first try to have an optimal medical treatment, and if it doesn't work and the patient is although has symptoms, then we are then it is suggested that we perform a TEER. As we can see here, it's a 1B classification that valve surgery or intervention should be recommended if the patient has a severe MR and remains symptomatic, although the medication is optimal. Also, I would like to say a little bit about the mitral bridge study that also tells us that they studied about 119 patients with a severe MR who were listed for transplantation or before a heart transplantation could be done. And as we see, the primary composite endpoint was achieved by 63.5% of the patients. The composite endpoint was that the patient could undergo a heart transplantation successfully. Patients that were too bad for a heart transplantation could enter the list with the M-TEER, and some of the patients, 23%, it's not small amount of patients, could be delisted because they were clinical, because of their clinical improvement. Taking all of this in consideration, we decided, the heart valve team of our hospital decided for our patient to undergo a mitral transcatheter edge-to-edge repair in order as a bridge to transplantation. In this patient, we did a mitral clip, and I will go through the video and say a little bit about the procedural steps. Of course, the patient was intubated. At start, we perform, although we have the screening TOE, we perform a screening TOE on the table in order to see in order to see again the leaflets and the jets, the optimal views. And the whole team, the interventionalists and the echocardiographer, and the anesthesiologist, the whole team of the operation discusses the goal of this procedure and what we want to do. In this patient, we decided to go with a medial clip and see how much MR is left and do more work through. We go from the vena, from the femoral vein under echo guidance in order to avoid a dissection, as you can see here. And after that, we go with the catheter. And afterward, we will go with a catheter to the right atrium, and we insert the needle for the transeptal punction. Everything, of course, is done under echo guidance because it's very important to have the optimal height for the puncture, as we need about 4 centimeters from the mitral valve ring. And, of course, the puncture should be done in the fossa ovalis. I'm going a little bit here where the puncture is taken through. You will see here the fluoroscopy and here a little about data about our hemodynamics. Here you see the catheter and the needle. This is here, and you see the tenting of the fossa ovalis. And we are doing our measures, everything under echo guidance. I'm moving in a little bit quickly in the puncture moment. Here you see the tenting. We do it always in biplane so that we have both views and know how much distance we have from the aorta. So in here, he goes through. So here's a moment. You see the tenting and how the tenting was released. We are, the catheter is in the left atrium now. And then we are going with the wire to the pulmonary vein for stability. You see it here, we are seeing the catheter and the wire is coming out. It's very important to see that it doesn't go to the LAA. That's why we are doing it always under echo guidance. So, and afterwards we are preparing the guide, the metric guide, in order to go above.
We can go a bit faster because we're in the break time already.
Okay. Here's the moment where the guide goes through the septum. Here it goes through. You see the tenting and the tenting release. And here comes the clip, who is outside. Then under echo guidance, we are guiding the clip on the mitral valve. And under 3D, we are performing where the orientation of the clip, how it's going under the valve, and then we are diving into the left ventricle after we decided the correct position of it. Under the valve, we are performing also 3D in order to see here, in order to see where the clip is, if we are everyone is happy for the position. And afterwards, I'm going a little bit faster. That was too fast. Here. Yes, we see here how the leaflets are in the clip, and the clip closes under echo guidance. Here, you see the leaflets in the clip. So we are performing afterwards our controls. If everyone is happy with the result, we had a residual 1 to 2 MR before the guide was released. We decided to let the clip in this position and do the afterwards control in order to decide if we are doing a second clip. That's the the result. We had a left MR of 1 to 2. As you see, the MR comes from this area. We have their indentation, and we decided to leave this MR for the patient. That's also the transthoracal echo from the patient, where we see that the MR is 1 to 2, and we hope that we helped the we help the patient, and that the follow-up is going to be better, and that we have made time for her for the heart transplantation.
Okay, thank you very much, Maria. We know when we perform edge-to-edge for mitral, we go for a 0 or 1+, but in this patient, who is a candidate for heart transplant, we were very happy with the actual result, because her destination, her therapy is going to be heart transplant. Thank you very much. So anybody, any questions from the panel?
Dr. Athanassopoulos, tell us a little bit about the timing of transplant and how did it go in your system?
Thank you, George. This is actually my comment. This is a very important procedure for us because, as you very nicely pointed out, one-fourth of this particular mitral bridge registry delisted. And, but on the other hand, our advanced heart failure patients are in a very delicate hemodynamic and prognostic balance. So we need to proceed with these sort of procedures to stabilize or even to improve the clinical status of our patients. On the other hand, we don't have to lose time in this sensitive category of patients to offer them the advanced therapies like mechanical security support or heart transplantation. So it's a very delicate balance, and of course, we have to select patients fulfilling the co-opt criteria.
Dr. Gkouziouta?
Yes, I would like excellent presentation. Thank you all for the kind invitation. I would like to make a comment on this patient, since we follow up her for the last 16 years. Actually, her deterioration was in CPET, and she couldn't tolerate all the four bigs, the drugs that we give in heart failure. So 3 weeks after the procedure, she's doing well, and she's taking all her medications. And we hope that after 2 months, she could perform a nice cardiopulmonary exercise test, so we could make decisions for her. As for your comment, and the comment of Dr. Athanassopoulos, for the patients that they may delay their listing for advanced heart failure patients, well, the point is that we have to select the patients that can be responders, be very close to them, because those patients are dynamic and may change their profiles. In concluding, I would like to share you our experience with our first mitral clip patient when we couldn't perform in our hospital 7 years earlier. And he was one of the candidates of this registry, and Dr. Spargias kindly helped us. He was transplanted a month ago, listed after all these years, not for deterioration of heart failure symptoms, but due to electrical storm. So it is of highly importance to, as Dr. Leontiadis mentioned, to change a little bit of their route if this is possible.
That's great. That was a long bridge, several years. And great, definitely worth. Any final comments? And anybody on the online, or the panelists online, please speak up. We don't see you, so I can't from here. So I'm not sure if you have a comment. Please go ahead and speak. Final comment from here, Dr. Athanassopoulos.
Or Nikos, maybe. Nico, would you like to make some comments? Okay. No, my final comment is that we experienced a great session, actually, a great educational. I would like to thank all the speakers sharing with us their great experience. Thank you very much.